And here is our topic for today, patient selection and office flow. Okay, so our general objectives and specific objectives for today are to review indications for medication for opioid use disorder, confirm appropriateness of the patients, consider potential barriers or stumbling blocks to treatment and how to overcome them, and then to review one structure of a visit that would meet clinical and regulatory requirements, think about how you'd adapt that in your own practice, and then to reflect a little bit on our own practices and boundaries concerning the objectives we're talking about today. Brief commercial for COVID-19, it's still with us, and so before we think about any interactions we'll have with our patient, we're going to be on the lookout for people who are symptomatic and need to get tested. I'm finding in our MOUD population, there's a lot of worry about contacts and potential exposure that sometimes people need to get talked to and reassured as well. And so that's still out there. Reminder that when we're seeing people in person, we should still be masking and social distancing, and that at this moment still there are some allowances for COVID-19, and one of them is that requirements for urine drug screens are waived. Requirements for a physical treatment agreement that a patient has signed is waived, and that patients may attend virtual counseling and meetings at this point. And that we should be alert for policy changes that can come from a variety of levels. I'm now going to make a commercial for screening in the context of screening, brief intervention, and referral to treatment. We might think, well, how's this relevant to us? Because we really are the treatment that people might have been referred to already. And I will say that over time, as I've experimented in using the parts of SBIRT, in my intake for patients, I've come to be a fan of it, and that's what it is. We know it's evidence-based and that it really allows us to find patients who are in need of services and different levels of care, at least to get started in that way. And sometimes we can find that by screening, we'll do something different in our treatment plan than we would have if we just assumed that we already knew about this person's substance use disorder. Screening, just as a reminder, starts in a very easy and manageable way with a one-question screener. How many times in the past year have you had 5 or 4 or more drinks in a day? 4 is for women, and for adults older than 65, 5 is for men. And just recently, there are some recommendations that we get rid of those gender-based differences and really go with that lower level for everyone. The American Cancer Association has just made a big statement that says, well, you know, while we used to say a little bit of moderate drinking was okay, we now say all drinking, all alcohol is hazardous. So this kind of cutoff for what's hazardous drinking versus what's reasonable drinking is changing. This is how these questions stand now because they're validated in this study by Smith that said if we want to distinguish between people that may have a problem related to drinking versus those that probably don't, this is the question to ask until our social norms change. Smith also did some work to validate this question. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? Asking those 2 questions, we would expect the patient to answer, well, you know, many times to the second one if they're seeing us because of their opioid use disorder. But they might answer differently, and we may or may not get that positive answer to the alcohol question. Any response greater than 0 triggers additional screening, and this can be done with another validated tool for finding out more about a person's alcohol use. The audit is a good tool to use, and for finding out about other drugs, the DAS-10 is the quickest and most manageable. We need to have a permission to use the DAS-10, and if you're using it for a clinical reason, you know, not to sell it or make money from it, it's very easy to get that permission. The NM Assist is a validated instrument that's much longer and harder to use. You'd have to sit down for a longer time, but it really looks at individual drugs that a person could be using and have either hazardous use or a use disorder. Why do the screening with our new patients who are coming to us for buprenorphine or some other way to treat their opioid use disorder? Well, just by backing up, we might potentially discover a hazardous use of alcohol that, you know, hasn't been a focus for either the patient or the person referring them. There may be an alcohol use disorder or hazardous use that we'd want to discuss with the patient so that they can use the buprenorphine safely. We might find a patient who truly has an opioid use disorder, and we're confirming that. We might find a patient who really doesn't have evidence for an opioid use disorder, who's really referred because of the kind of current wave of opiophobia, a person who's been using an opioid in a prescribed way without evidence of a use disorder, but who's lost their prescription and who has enough tolerance, dependence, and belief that it's helpful for them, that they want to be able to continue an opioid in some way, and they've kind of washed up on our shores to be treated with buprenorphine or a different opioid agonist. Fairly frequently we see those patients coming to methadone treatment where, you know, they don't really have an opioid use disorder, but they've been on a fairly high dose of an opioid for a long time, and the prescriber, who doesn't want to prescribe that anymore, just hasn't known what to do with them. Doing this screening helps us to defocus from the drug of abuse to the disease of addiction. And it helps us to get away from asking that patient to tell us their inventory of all the bad and shameful things they did while they were on drugs. Tell me all about your drug use. When did it start? What happened next? How many times have you failed out of treatment? And lets us instead ask some pointed, directed questions that help us to say, you know, yeah, you really do have this disorder of opioid use disorder, and that we have ways to treat that and manage it. So I've liked it as a way to get off on the right foot with the patient, just to do some screening. I find it helps to reduce shame and stigma, and to remind us all that what we're doing is looking for a disorder and treating that. I'm having a little sticky key problem today. Okay. When we've done that screening, we can move on pretty quickly to trying to confirm a diagnosis of opioid use disorder, because we really need to have evidence of that diagnosis if we're going to prescribe buprenorphine for opioid use disorder, not for some other reason. It comes as mild, moderate, or severe by DSM-5 criteria, and it's pretty easy to confirm or to look back on notes we might have already received and not, you know, have to retread all of the work that's been done by a previous evaluator, but to confirm that we have a diagnosis. The other diagnoses that we'd want to think about are medical, psychiatric, or chronic pain diagnoses that are going to have an impact on the patient's ability to do treatment. And occasionally we might find a patient who doesn't have opioid use disorder who really has chronic pain and is referred to us. Sometimes it's not all that clear. Tolerance and dependence don't alone define an opioid use disorder, but with one other kind of peculiar aspect of use, like the person has trouble not using their opioid, or, you know, we'll kind of see when you're looking down that list of the 11 items, often that person with chronic pain who's been on will be able to qualify in at least as having a mild use disorder. And in that situation, our opioid that we're prescribing is really going to apply to both of their problems. Butrans and Belbuca are both approved just for the treatment of chronic pain, and a DEA waiver is not required to prescribe those particular medications, but we shouldn't be prescribing them for opioid use disorder. Less desirable is it's perfectly permitted to use buprenorphine naloxone, the films or the tablets, off-label for pain. I just don't like using things off-label. That's me, so I'd prefer not to do that if I could avoid it. Here are those 11 items just for you to have as a reference. But you can see that that person who's been on oxycodone for decades may have had a desire to cut down or control their use and hasn't been able to. They most likely have tolerance and withdrawal when they, are kind of cut off from their supply. And they may have some other thing going on, like social, occupational, recreational activities that they haven't been able to do, where it's not completely clear to us, is that because of the limitations imposed by their chronic pain, or is it an effect of the opioid that they've been using? So there's a way to think about those patients. Substance use disorder, the bottom line is it's a problematic pattern of use that leads repeatedly to clinically significant impairment or distress. And for most of the patients we'll see, it's pretty easy to know that they have that. If we break up those 11 items, we can see that there are 3 themes there. There's loss of control, repeated use despite negative outcomes, bad consequences, and there's physiologic complications of tolerance and withdrawal. The scoring is pretty simple. So for that patient that's scoring 2 to 3, that's a patient you can just kind of bring into the fold and say, I'm comfortable treating with buprenorphine naloxone because it appears there's an opioid use disorder that's either present or would develop over time. And most of the patients we see are going to fall into that severe category where there's no question of that disorder being present. Why have we done this screening and confirming this diagnosis? Well, of course it's partly for us, but there's a really nice sideline, and that is thinking, what's the patient's experience of going through that assessment? Miller and Rolnick are the, kind of big originators of motivational interviewing, and very early on they came up with this kind of tag phrase that for me really encapsulates what's motivational interviewing about. When I hear what I say, I learn what I believe. So we can lead that patient to tell us all about their shame and their inability to get better and stay sober and do treatment, or we can lead them to tell us and themselves, I really do have a disorder. I've been trying. I'm interested. I want to move forward, and I have a legitimate disorder that there's treatment for. That I find is a nice way for me to take a good first step, and also for the patient. Confirming an indication, this is a little pedantic, I guess. We know we're going to use methadone, buprenorphine naloxone, or injectable naltrexone for those patients with opioid use disorder, but there's a little distinction between them, that when we're using those opioid agonists, what they're approved for is to treat opioid dependence. When we're using injectable naltrexone, it's approved for alcohol use disorder and to prevent relapse. There doesn't seem to be that much distinction there. The one thing to take away is that oral naltrexone doesn't work well for opioid use disorder. It's approved to treat alcohol use disorder and for the blockade of exogenous opioids, but that's not enough to treat opioid use disorder. Naloxone is the other medication we use, and that's the one that reverses an opioid overdose temporarily. When we come to patient selection, we know from tip 63, there are a lot of ways to define an appropriate patient, the one that we would love to see every time coming into our office. And you can see all of the great things about them. They already have a diagnosis, or it's easy for us to confirm it. They're interested, they understand the risks and benefits, they're going to be compliant, they have everything they need to get to their visit, a car, the time, a way to tell when they have an appointment. They're psychiatrically stable, they don't have other illnesses that are going to get in the way of their treatment, they don't have problematic medications, and they have a supportive environment. Well, we would love to have that patient. That's usually not our patient. I will tell you, though, that in my practice, I just recently got 2 patients sent to me by by a prescriber who's retiring, where I said, wow, you know, these are patients who've been in MOUD for more than a decade, and they really are meeting these criteria. They didn't, they told me, you know, and we confirmed when they first started, but they do now. Most of the time we'll see these patients, someone who for some reason we would consider maybe to be less appropriate or more problematic. And you can kind of think about your own patients and who would fall into these categories. People who have high doses of benzodiazepines or using alcohol or other CNS depressants when they arrive, who have significant psychiatric disorders, including suicidal or homicidal ideation or attempts. That always raises an alarm bell. Who've had multiple previous treatments and relapses, and now they're coming to us. They have a lot of physical dependence and withdrawal. Patients whose needs can't be met with our office resources, whatever they are, they're going to need to have a kind of a virtual team of people to take care of them, and who are at high risk for relapse for different reasons. And then those people with a poor support system, which, you know, we'd have to think when people are starting out in treatment, we might think that's actually the majority of patients, not the exceptions. You might think in your patients of other features of those patients that they could think, wow, this is going to be an uphill climb. Is this patient really appropriate for my program? Our message here is that over time, we have gotten more towards thinking buprenorphine naloxone really works. It really helps people to get better, to have a better life, and to avoid a death by overdose. And that when possible, instead of looking for impediments to treatment or trying to send that person to, I think what Dr. Goldman calls that kind of mythical higher level of care, we ought to think, can I work with this patient? What would I need to do? How can I build a bridge so that this patient can get treated in my office-based setting, not to set up barriers. There are some barriers, though. There's stumbling blocks. There are things that need to get taken care of. And the next couple of slides address those. A patient who has an important co-sedative needs to have a plan around that. That would be mostly benzodiazepines, alcohol. Occasionally, there's a patient who has a barbiturate prescribed to them for some reason, or who has other CNS depressants that aren't necessarily going to interact with the buprenorphine, but are going to cause them to appear sedated. That would be, you know, kind of sedating antipsychotics or sedating SSRIs. So we could think this is a patient who might need to do a medically supervised withdrawal from that sedative and needs to have a plan around how they're not going to be continuing to use it and what they're going to do instead. So here are some kind of ways to do that. We may decide we're going to need some help, and in that situation, call on one of our consultants. For me, because I'm in a primary care setting, I will want that patient to be linked to a psychiatrist who's going to help them to manage whatever the problem is they've been using that sedative for. Sometimes the problem is just plain and simple. It's a use disorder, a benzodiazepine use disorder. And in that case, tapering, working with that patient to be doing other kinds of psychosocial interventions and counseling that would be supportive for them, and then looking for an anxiety disorder or PTSD to unmask itself along the way are what works the best. Alcohol sometimes is just not considered an important or hazardous drug by people who have an opioid use disorder, and it's difficult to track in people who really feel like it's okay for them to have an occasional drink and they're doing that, but it's easier to see in people who are obviously dependent. We can track labs, we can get a breath test, we can document that we've educated those patients and that we're going to be watching out for signs of a mild, moderate, or severe alcohol use disorder along the way. And very often, if a person is orienting themselves to the abstinence-based way to think of recovery, they'll want to get their alcohol use eliminated anyway, and we'll be working in the same direction. What about benzodiazepines? The very old approach was toxic combination. The newer approach, because we now have data, is that using a benzodiazepine does not set the person up for an overdose or for a death, but it does mean that they're likely to have more side effects, like to appear sedated. So the new recommendation is don't withhold buprenorphine from patients using a benzodiazepine, either illicit or prescribed, because the risks of the opioid use disorder may outweigh the risks of co-prescribing. Cessation of use is what's preferred, and it's a reasonable goal. Tapering or medication, medically supervised withdrawal, formerly called detox, might be either one of those might be adequate, and that the patient may be treated concurrently for a benzodiazepine use disorder while they're receiving medications for opioid use disorder. It's not a condition that the benzodiazepine use disorder be controlled before treatment for opioid use disorder starts. In fact, it's the opposite. That said, here's a summary of some fairly recent evidence from 2018. In 2013, almost 1 out of 5 patients receiving buprenorphine also had a benzodiazepine, and looking at those patients allowed us to say that it's not a situation where the hazards outweigh the benefits. Co-prescription increases risk of side effects again, but not overdose and death. However, short-acting alprazolam, that Xanax, is the benzodiazepine most frequently involved in an overdose, and we should avoid that co-prescription. In fact, maybe some psychiatrists will weigh in later for us to think about, is there ever a situation where a patient needs to have alprazolam instead of a different benzodiazepine or a non-benzodiazepine for anxiety or for other reasons? So that is a red flag, alprazolam. Who's prescribing it and why, and how can that be eliminated? What about other drugs? Here's a slide about stimulants, which are increasingly seen, and either as a contaminant or as a kind of a new drug of preference. And again, there's data to say, don't wait for that person to control their cocaine or methamphetamine use before prescribing medication for their opioid use disorder if they have a legitimate opioid use disorder. If it really appears they don't have an opioid use disorder, but they would like to get some buprenorphine to be able to sell it or barter it, then that's not a reason to prescribe buprenorphine. But if there's a co-occurring disorder, again, preventing an opioid overdose death while the person's deciding what they want to do about their cocaine or methamphetamine is reasonable. We might have in our own practice a kind of boundary. If if that patient decides they really like cocaine or methamphetamines and they would like to continue using those in an uncontrolled way, that might be a barrier for us where they're really not going to be, we're not going to feel like we're able to treat them in a way that's going to have long-term effectiveness. And that's for each of us to decide. Marijuana, again, data is not forthcoming. It's even harder to really sort out what's going on, since some people have some sort of controlled use of medical marijuana. Although you can see, if you have patients, they really can pick that up anytime, and they can use as much as they want, in different types, different CBD to THC ratios. So I think it's really hard to know, how harmful or helpful is marijuana going to be. But again, there is no evidence that concurrent use of marijuana is hazardous to a person who's having medication for an opioid use disorder. We might be working on cessation or working to have that person really evaluate whether their medical marijuana is helpful for them or not, and to be relinquishing that if it's not. And we also know that marijuana does contribute to symptoms that would be interesting to us, like psychosis, anxiety, and bowel symptoms. Often will worsen over time as a person uses marijuana. It's like when you're thinking about how your spouse was on your honeymoon and how great they were and everything, and now you're on the brink of divorce, but it's somehow hard to think of that spouse as being so different than what you expected. It can be a kind of a grieving process for people to say, my marijuana is really harming me. It's not helping me the way that it initially I thought it was, and to relinquish that. That's why when we see studies for this group, we really would like to see long-term data, not just what happens in the first 3 to 6 months, because this can be a long process. So a change that has happened is that you may find in your community that treatment programs are permitting that medical marijuana. They're not looking at it in the same way as illicit marijuana anymore. You can track it on an ORS. You may find that you're going to limit a patient's privileges because you really want to have more surveillance of that patient. You're expecting, if a patient has medical marijuana, that they're going to have medical and functional improvement, not slipping backwards. And those are all kind of conditions that I think are reasonable for each of us to set. Illicit buprenorphine is an issue. That patient that comes and says, well, you know, I really don't need to do all of that induction initiation because I'm already taking 2 buprenorphine strips a day when I can get them, and that's doing me, you know, well. What do you do with those people? Positive experiences with non-prescribed illicit street buprenorphine were a central factor in participants' decisions to seek buprenorphine treatment. So, you know, we want those patients to make that transition from illicit to prescribed buprenorphine as soon as they can, and they're usually seeing us because they want to do that too, so we shouldn't see that illicit use as an impediment or an indication that they're not going to do well or they're going to have other illicit use of other drugs. We ought to see it as a motivator. There's not enough treatment in Ohio. We are one of those minty green states, which is, you know, kind of right in the middle. We have some prescribers, but not enough. We have 12 to 16 prescribers per, I think that's per 100,000 inhabitants, which kind of doesn't mean too much. But if you look at the red states, those are high prescribing states. And if you look at the purple states, those are states that don't have a lot of prescribers, and we're somewhere in the middle trying to get more people into treatment. A study that you might want to refer to, you know, when we get those patients, can we predict how they're going to do? This is a study that says if people are still using an opioid when they've been on a reasonable dose of buprenorphine for 2 weeks or more, they may be attached to that opioid and getting high and how it feels to the point where they are not going to do well with buprenorphine, at least not at this time. Then on the other hand, the study also said that those people that were abstaining from opioids early still might find themselves slipping back to using an opioid at some point and might need several times of reorienting, thinking about what their goals are, thinking about if they have an adequate dose, thinking about if their psychiatric and medical comorbidities are taken care of enough before they're going to really get traction and have success. So that's the take home from that study. And then thinking about our patients with the various possible stumbling blocks. I think the next slides just say there's answers for everything. Making sure that our patient has an adequate dose. If they say, yeah, I was in a buprenorphine before, it didn't work for me. You know, how much did you have? 4 milligrams, 8 milligrams? There's likely a reason that wasn't working and that person was underdosed. Psychosocial supports, more structure and accountability can be helpful, managing relapse and trying again. Psychiatric comorbidities, most of us don't have integrated care, so I'm always trying to make sure that that person has a psychiatrist and that I'm communicating with that person when I need to, and then considering those longer acting, less administration Sublocade and Vivitrol for those patients. Coordinating care is really helpful, and a key to this sometimes can just be a primary care provider. So for that patient that says, yeah, I go to the emergency room whenever I'm sick, that person also likely has insurance that would enable them to get a primary care provider and they just need some instructions in how to do that. And then that person will take care of a lot of this coordination for us. Thinking about office flow, we want to know that in our appointment we're doing all the things that the Ohio Administrative Code tells us to do. And if we have a sort of a standardized visit, we'll always be doing those things. Stress-free, gives us time to build relationships with patients when we don't have to always be thinking, what do we have to do? We're always thinking about that DEA visit, which, you know, has or hasn't happened for some of us. What we need to have is our current state license, our up-to-date DEA controlled substance registration certificate, photocopies or an electronic copy of both of those will do, and a list of our patients who have an active prescription from us, up to 30, up to 100, or up to 275. It's really important to not exceed the number of patients we're allowed to have. So if you have to think, do I have 98 or 102, you know, you really want to look at that and be comfortably within that limit. And that's what a DEA visit requires. And they may look at a note and see if we're doing the things that we need to. Here's, just for your reference, some things that could be components of a templated note that would capture the lab tests that we need to do for a patient, the urine drug screening, the fact that we're looking at an ORS report and making an assessment of that, and the fact that we're doing some treatment planning and having a treatment plan for the patient. Whether that patient is one of those perfect patients, or if they're a person where we have a treatment plan around their use of marijuana that we're not expecting is going to result in abstinence anytime soon. The treatment plan is there and it's templated into our note. Between visits, you may or may not be doing something with your patient. You may have a delegate who will help you to manage your charts and manage things that may come back, like a lab test or a report from a consultant. Sustainability is our goal. So some of the things that I get help with from our office social worker, making sure the person has insurance, they have transportation, they are scheduling to avoid missing visits, and that my expectations of their other activities are realistic. For example, for a person who works and really wants to keep their job, I'm not going to be calling them at random, telling them to come at 2 in the afternoon for a drug test. I'm going to plan around that. And that I have a plan to manage a relapse if it happens, because relapse happens and they're not a reason for us to have a person leave our program. In fact, they can be a reason to intensify that program. Helping patients achieve health and life goals. COVID-19 updates, again, maintaining that presence for the patient, however tired we are of our Zoom appointments, just having them know that we're going to be there, getting our drug screens, treatment agreements, and having that patient do some counseling as soon as that's available for them, and making sure that people have Narcan, since there's been a rapid uptick in overdose and overdose deaths since social distancing came into effect. There's some references, and I will stop sharing my screen.
Thank you, Dr. Marsh.